Bismillahirrahmanirrahim. My dear students, today I am discussing the Mucoepidermoid Carcinoma, what are its grade, histology, different histological pictures, case presentation, what is the gross examination, immunohistochemistry, cytogenetics, and the MCQs. Good morning from the Muzaffarabad, beautiful view. You are looking behind me at the mountains on there, the beautiful road coming from Mansehra to Muzaffarabad. Hopefully very soon this will be built a motorway from that will connect Muzaffarabad to the Mansehra. And I am sitting on the bank of the Neelam Valley, and you can see on the left side greenish yellow water of the river Jhelum. So the first case presentation, a 45-year female presented with left-sided enlargement of the parotid glands for the 6 months on cross examination. Was uncapsulated, but it was well circumscribed on cut section. It was cystic. The cysts were filled with the mucus-like material, mucoid material. But the FNAC revealed pleomorphic adenoma. What could be the diagnosis? Sebaceous cell carcinoma, low-grade epidermoid carcinoma, lymphoepithelial cyst, mucinous cystadenoma. Because it is cystic, that is why we included the differential diagnosis, mucinous cystadenoma. Could be the benign examination. If you reveal the picture very soon, you will see it is the low-grade carcinoma on the history. This is the gross examination. This is the histological examination of the picture. You are revealing a cyst, secretions, clear cells, and surrounding the cells are cellular area. You can see a few area of the chronic inflammations. You can observe the joint cell. This is again pictures of the cystic areas and high power view. You can differentiate different cells. And in this picture, you can see clear cells, columnar cells, mucous cells, intermediate cells, fibrosis. So the histology revealed case 1, cyst, one thing, variable size, 3-4 types of the cells were in surrounding this mucus, intermediate epidermoid, clear cells, cysts, surrounded by fibrosis, inflammations, chronic joint cells. The tumor was not invading the Martian circle here, but approaching. Another case, 56-year female presented with the parotid tumor for 5 months, causing pain. History is very important to read. Facial palsy for a few weeks. FNAC is alarming, suspicions for the malignancy. On cross examination, this was cysts and solid area. What could be your diagnosis? On the history, it is above the low grade, more than the low grade. Could be intermediate, could be high grade. So histology is very important to see the squamous cell carcinoma. It is the second low grade. No, this is the solid area, there is small cyst. Cross examination, histological examinations. Almost more than 30% of the cystic, more than 70% of the areas are solid, but cysts are there. Intermediate cells, clear cells. Solid area, atypical areas. So this is the intermediate. Case 3 is 60-year-old female. So one thing is very important, that this tumor is more common in the female, variable age. Cross-examination is changing from partially capsulated to uncapsulated, cystic to solid, necrotic time. So the history is changing. You must read the history before making the diagnosis. Low grade, it is above the low grade. When it is necrotic area, it is always high grade tumor. Histopathology of this case, histological examination of the section reveals tumor. There are solid cystic area replace most of the parotid parenchyma. Cyst growth is not apparent in most of the sections. Neoplastic cells forming cohesive sheets against the desmoplastic reaction. The nuclei of the neoplastic cell are enlarged, irregular, and prominent nucleoli. These all are the features of the high-grade tumor. Mitotic activity is there, variable brisk. Although the tumor cells are epidermoid appearance, and it means squamous appearance, but prominent parotid pearls are not seen, which are more present in the squamous cell carcinoma. And cellular bridges are not seen. Occasionally, the cells are foamy, but goblets type cells, you can do the mucoepidermoid stains to make the differentiation of squamous cell carcinoma, basal cell adenocarcinoma, and the high-grade tumor. So this this mucoepidermoid stain will reveal the presence of mucin vacuoles in some of the cells with foamy cytoplasm. This is very, very important for the undergraduate students and the postgraduate students. What are the different positive markers? And what are the different negative markers? What is the cytokinetics molecular kinetics of this? These are the 5 questions. Which type of carotene positives, EMA positive, CE positive, 63 positives, SOX10 negative, ascended negative, calpanin negative, actin. So translocation of 11, 19 is positive. The description for the undergraduate student, most common malignant tumor of the cervical glands, mostly in the parotids, each variable, second, third, fourth, fifth, could be the large range of the age, could be seen in the children's. First reported in 1945 by different pathologists, can be seen in the children. It's the only cancer that can be seen in the children. And we discussed in previous slides the different cytology, histology, presence of intermediate mucous cells, clear cells, epidermoids, and the proportion when varies, it causes the grades. No doubt the grades are very important, but has been continuous more important is the histology. When it is becoming solid, cystic to solid, the grade reveals. The histological picture, some things are very important to note. The presence of mitotic activity, anaplasia, perineal invasions, solid growth, necrosis. So this will make the tumor high grade. Etiology is still unknown. Therapeutic radiations. Chemical carcinogens. But in Warthin tumor, we noted Smoking and Epstein-Barr virus could be the etiology in the Barthen tumor, but what are the origin site? Usually from the ducts, salivary gland, excretory and intercalated ducts. Clinical features depends on the grades. Age is variable, more in the female, can be seen in the males. Parotid, but hard palate is intraorally in the minor tumors. As we discussed, more can be seen grade, low grade, solid, cystic to solid. This is the clinical grading, how painless, tumor, smaller size, maybe capsulated or partially capsulated, cyst filled with mucoid, viscoid material, maybe mucosal. High grade, it becomes more solid, facial paresthesia, more symptoms of ulceration, trismus, draining from the air, or when it is parotid, dysphagia, when it involves the esophagus. And there is metastasis, the region leader is very important. This is the hard palate tumors. This is the tongue tumor. So genetic is we discussed different chromosomal loss, 9q, 8q, 5p, variable translocation we read in previous class. The genetic HR is very important, cross-examination. Low grade, you can see cystic mucoid areas. On the tongue area, you can cut sections. So histopathological features, we discussed different variations of presence, constant ratio of the mucus secreting cell, epidermoid cell, intermediate cells, columnar cells, mucus cells. When more than 30% low grade, then in the high grade, you have to use the mucicarmine to identify the, could be these are mucus cells are cuboidal, ovoid, columnar, goblet cells, clear for mucicarmine, pH strains. These are similar to the squamous cell, could be polyintermediate cell, smaller than the basal cell, larger than the basal cell, but smaller than the squamous cell, larger than the myoepithelial cells. These are the progenitor from here, the squamous cell arise. Clear cells are larger, polygons. These are the different pictures. You can see this is the clear cell, these are the squamous cell. These are the intermediate cell. I will show, give the presentation. And this is the mucus producing cell, clear cells, intermediate cells, squamous cells, fibrosis. Mucicarmine stain, you can identify, use, and especially high grade tumor. When the more solid area, this is intermediate grade. The very important thing in the cytological morphology is to make the tumor high grade, and then here is the squamous cell carcinoma will come in differential diagnosis. Final aspiration after the high grade, note the predominant squamous cell, and you can see here mucus cells, you can see goblet cells, you can see the mucus vacuole, mucus is also there. High grade tumors, solid areas. So this is just to show you different increasing availability of molecular genetics in mucoepidermoid carcinoma translocation as 1119, that is called MECT1 MAL-L2 translocation is very important. This is the pleomorphics to make the differential diagnosis. Black. Differential diagnosis is very important for the students and also for the clinicians. If it is high grade, what could be the differential diagnosis? Squamous cell carcinoma could be primary, could be secondary. Keratinization is there, intercellular bridges are there, lack of intermediates. Mucocyte and mucicarmine is negative. Cervical gland duct carcinoma, GATA, HER2 androgen receptors are positive, shows a Roman bridges, similar to that of the breast carcinoma, cuboidal necrosis there. When it is low grade or intermediate grade, it could be the necrotizing shallow metaplasia. It could pattern may be lobular. Lack of cystic pattern you see in the low-grade carcinoma, mucoepidermoid, no intermediate cells are there. Pleomorphic with squamous or mucinous metaplasia. Pleomorphic adenoma could be with the sebaceous metaplasia composed of epithelial, myepithelial cell, extracellular matrix, cartilage, and Warthin tumors can confuse. Lack of translocation of the mucoepidermoid carcinoma shows bilateral oncocytosis. Acinic carcinoma, DOG1, SOX2 memory, analog, S100 proteins. Treatment is depending upon the grades of the tumor and the involvement of the facial. You have to save the facial nerves and how to remove. Otherwise, there is a danger of the recurrence. So this is the MCQ number 1. 45 years female presented with the left-sided enlargement of the parotid for the 6 months. Which of the following is true about the mucoepidermoid carcinoma? This translocation, fear genes, high associated with smoking. Most common malignant salivary tumor in the children. Positive prognosis. A is not seen in the mucoepidermoid carcinoma. B is not associated, it is associated with the Warthin tumor. D is for the duct carcinoma and salivary, ductal carcinoma and salivary. Prognosis is poor depending regardless of the histology. No. So the answer is most commonly occur in the children. Another MCQ is 60 years female was diagnosed MCQ, but to create this tumor, which after following histological feature is commonly seen in the low intermediate mucoepidermoid carcinoma. We see the tumor was breast mitosis, in low grade, these are not seen. I discussed that intracystic component more than 30% is the sign of the low grade tumor. Perineal we are not seen in the low grade tumor. The third MCQ question is logical examination of the reveals focal clearance cell changes seen in the mucoepidermoid carcinoma. What is the cause? Accumulation of glycogen, accumulation of mucin, degradation of neoplastic cell, fixation artifact, high-grade transformation. It is due to the glycogen transformations. Another MCQ is the children. It is the 12-year child present with the mass, commonest salivary tumor in the children. Lymphoepithelium, pleomorphic adenoma, adenoid carcinoma, mucoepidermoid carcinoma, This is the mucoepidermoid carcinoma. Another MCQ, high-grade tumor was removed from the tongue. It was almost spindle in shape. Spindling is seen usually in the pleomorphic adenoma, no. Adenoid cystic carcinoma, no. Basal cell carcinoma, no. Basaloid carcinoma, no. Squamous cell carcinoma, yes. An ectopic salivary gland tumor was removed, was malignant. Ectopic is usually seen in the tongue, no. Cheek, ectopic, no. It is the most commonly seen in the palate. A large tumor was removed from the parotid and histology revealed intermediate cells and led us the witness the histological tumor that contains the intermediate cell. Adenoid cystic carcinoma, no. Mucoepidermoid carcinoma, yes. Polymorphic adenoma, no. Warthin tumor, no. Another MCQ question, salivary glands tumors are very rare with unknown etiology. Which of the following salivary tumor has highest rate of malignant transformations? Parotid, submandibular, sublingual, tongue, palate. It is the parotid. Another MCQ questions, 80-year-old female was diagnosed as high. You have seen in the presentation, third presentation, but seen following are high-grade salivary glands, except basal cell, no. Mucosa epidermoid, yes. Adenocystic, yes. Salivary gland tumor, yes. Eosino carcinoma, no. It is the basal cell carcinoma. These are the teachers. This is the PAP conference in Islamabad. Eminent teachers all over the Pakistan, from Karachi to Peshawar, from Azad Jammu Kashmir, histopathologists, microbiologists, chemical pathologists, immunologists, hematologists, and best of luck. Thank you, my dear students. You can ask the question at the end of the sections I have given in the question areas, and hopefully today's lecture will help you in making the sense to reply the MCQ question and making the diagnosis in the laboratories. How to diagnose? Clinical history is very important. FNAC is the second tool, and the third is the biopsy, cross-examination, and histopathology. These are the important. There is very less role